Our next speaker is John Kirkwood, Dr. John Kirkwood, who's done most of the work around interferon and knows more about interferon than anyone else, has been a leader in the field. His formal title, let's see, Director of the Melanoma Center at the University of Pittsburgh Medical Center, Professor of Medicine, Dermatology, and Clinical and Translational Science at the University of Pittsburgh School of Medicine, and the Clinical Translational Science Institute at the University of Pittsburgh. I'm telling you, how you get this on business cards, I don't know. His research is focused on the development of new and effective treatment options for melanoma, pioneered biological treatments for melanoma that ultimately provided the first adjuvant therapy for treating patients with high-risk melanoma, leading several clinical trials with cancer vaccines that serve the body's own immune system. And I don't know, Dr. Kirkwood, if you're going to say this, but I'll say it about you. I was really struck by a conversation we had a couple of years ago where he said, you know, my entire career I've been dealing with people who have advanced melanoma, and I'm just tired of seeing so much advanced melanoma. So he also has launched a major effort out of the University of Pittsburgh focused on prevention, because he said maybe we can have fewer people getting advanced melanoma, and that's another way of having an impact. And I just think that speaks very much to the heart of what a true medical oncologist feels, is we want to deal with every cancer patient we have, but we want to have fewer cancer patients too. So, Dr. Kirkwood.
Thanks, Tim. Thanks, Steve. Thanks, Shelby. Basically, our mission in academic medical centers is to teach, but it ain't to teach fellows. It ain't to teach residents. It isn't even to teach the medical students who are in my clinic. It's to teach you all, because patients and patient advocates have far better penetration than any of our professionals. So I'm going to walk you through stuff that is frontline, current clinical trial data, because I want you to know about what the trials are that are out there. And I think the stories we've heard, Bobby's story, Cadence's story, are incredibly meaningful to me. I won't have time to talk about, is this working yet? It ain't. Okay, I can hit the button there. I know how to do that. So my disclosures. The area that we work in is the top of this Mount Everest, the red block, advanced cases of melanoma, 9,000, 10,000 a year. The ones that we see immediately, or in the past immediately, are a risk to survival. The place we began 30 years ago is this zone I'd like to get to, but it's only the second part of what I was supposed to do, so I'll be a little bit, the question of adjuvant therapy, where I think the numbers are 3 times larger, and as we heard from Bobby, as we heard from Cadence, the potential opportunity that the drugs we have, which work this much in metastatic disease, may work that much in the earlier microscopic, potentially surgically curable disease setting. And as Tim just said, I decided after we did 10 or 15 years in metastatic disease, you know, the brain metastases, the liver, and so forth, and then we did 20 years in the adjuvant area, that we ought to spend the next 10 or 15 years teaching people how to detect this disease, because if you detect it earlier, if you detect it half as thick, the survival is twice as good. And there's already one data bit that I won't bore you with from North Germany where they did this. They taught primary care physicians how to look, and son of a gun, the disease they picked up was half as thick and the survival was twice as good. So I won't get to that data, but the whole question of what pediatric melanomas mean is even more telling. And so we began 10 years ago a pediatric melanoma registry, 800 cases of this, and then we decided to take it to our spores, as Tim already said, pretty well-funded institution that at Moffitt with Jeff and with Pittsburgh with me and with Ruth Halliban at Yale and with Maynard Herlin at Penn and with Liz Grimm at MD Anderson, now Patrick Hu, are 5 beacons of places that might actually understand how to get pediatric melanomas picked up without a screw-up in the diagnosis every time. And so, but we won't get to talk about that now, but just it is a part of our agenda. So, distant metastatic disease, inoperable melanoma, what we call stage 4, is the top of this pyramid. One of the things that I think you all need to know is that we now divide this disease up. And one of the things we won't talk about is BRAF, but half of melanoma in Caucasians is mutant for a gene called BRAF. And we have extremely effective drugs to stop this vehicle called melanoma in its tracks with the specific inhibitors for BRAF. Not one, not two, but soon at the end of this year, 3 different BRAF inhibitors. And they work better with a second inhibitor called MEK inhibitors, and I'm not going to bore you with all of that. But the subsetting, the divide and conquer that is relevant today is something that Jeff already talked about in his elegant presentation at the beginning, that if we could just figure out if a tumor was inflamed, had T cells in it, had PD-L1 in it, this would tell us who might be the more susceptible to these immunotherapies, these take-off-the-brakes therapies that are there. And so these, and you've heard about 2 smashing results from IL-2. You'll hear another, I guess, after my talk. Ipi approved in 11, Pembro and Nivo approved in 14. Ipi plus Nivo, the final combination Jeff talked about, approved just last year. As an adjuvant therapy, the approval of Ipi last year also, I think, means we have multiple new approaches, but the density is 10 new agents in metastatic disease, that top red part of the pyramid. We only have got 2 different classes of agents as adjuvant therapy, and we need to approach this to cure this. I put the portfolio of drugs that you all have heard about for melanoma here. The chemotherapy, which is what we spent from the 60s until the end of the 2000s using, I haven't given to a patient in 5 years. I think that's a welcome opportunity to avoid using drugs that are toxic to a bunch of organ systems beyond the melanoma and don't work, as Jeff already alluded to, durably. Immunotherapy, targeted therapy, the 2 other big classes, the focus upon, of course, the immunotherapy today. So this is the approval basis for 2 anti-PD-1 agents reviewed just at this last year's ASCO meetings. And these data for Pembro in the blue and the yellow compared to Ipi are what have led to a change twice in the past 4 years in the standard of care, because it used to be Ipi is the standard of care for metastatic disease, and all of a sudden that wasn't tenable anymore. You had a drug 3 times more active and 1/3 as toxic, the yellow and the blue. So these data Jeff went over, I'm going to skip through. The other point is, though, we still haven't licked this. And we basically have here the data that Jeff also talked about for PD-1 progression-free survival. That means the time until disease gets bigger. And I submit we need much more to do. It's better than the purple, which is the Ipi, but we still have more than half of people who need other therapies. So we have response rates that are impressive, and with 2 or 3 weekly Pembro, the fact that you have major responses and complete in the hatched part of this is a striking finding, because if there's something that tells us up front that we have long-term gains to look for, it's a complete response, whether it's T-cell therapies, even chemotherapies. When they work completely, they mean long-term benefit, but the fraction of complete responses here are a huge impetus to us on the medical side, I hope to you all on the patient side. But the downside, the side effects in the thyroid, interestingly, and this is interferon alpha. The first drug we realized would give people thyrotoxicosis, overactivity, thyroid paralysis, hypothyroidism. And we'll come back, but as Jeff already alluded to, those people were the people who got the benefit of the treatment. Similarly here, there may be some toxicities that augur for the better, some like colitis that are a big issue and still may be fatal in 1% or 2% of patients. And these are the things we have to overcome. So with the approval of the first combination, the question of what to do for combinations is, I think, a pressing one for us, pressing one for you to know about. And Jed updated this experience with the trial that Jeff alluded to earlier at the cancer meetings just in June this year. And I think these data are hugely encouraging to us for the orange, the combined anti-PD-1, anti-CTLA-4. But when you think about it, if you came into this and you could get this kind of benefit with 1/3 of the toxicity and maybe salvage things, as Jeff alluded to, by giving the other drug only at progression, maybe we'd have a better total package for the patient. So I think this is the burning question for us. I'm going to skip these details because it's short in time and I know many more topics to hit. The question of what the PD-L1 means, I alluded to in the beginning. Inflammation of the tumor, a hot tumor, is what we want to treat. PD-L1 is an indication of heat, of activity of T cells in the tumor. And this is very important for us to understand. I think how to heat up the tumor, we've got new tools to approach. And in a patient who is not benefiting from anti-PD-1, one of the questions was, can we use other things to stir up the pot, to heat up the tumor? T-VEC, you may all have heard about it, our first approved oncolytic virus therapy, may heat up the tumor, may by so doing make anti-PD-1 better. So Georgina Long presented for a group of us who've been investigating this, the possibility of putting T-VEC, a virus that inflames the tumor, induces immune response together with the anti-PD-1 called pembrolizumab. And these are the waterfall plots that show benefit, shrinkage in the tumor. As Jeff already presented, waterfall plots. I think it's interesting that Tom Gajewski, one of our more illustrious members in Chicago, used to say that we always saw geyser plots in melanoma. Everything got bigger. Now, for the first time, you see a majority of patients below the line, smaller disease. This is encouraging. These are spider plots. If you see these, that's just illustrating each individual patient with a line over time. And I don't need to bore you with this, except that progression-free survival is encouraging here. It's early days, it's small numbers, we need to see more, but maybe stirring up the tumor may be a way to get our drugs, PD-1, CTLA-4 blockers, to work better. How long do we need to give these therapies? This is a key question, and it isn't answered yet. We need trials that are rigorously going to stop at a particular time point and see, do we find better outcome? We heard this year at ASCO that people who got complete responses could, with relative impunity, stop these treatments. That's a huge benefit. If you can stop 3, 6, 12 months after you get a complete response, less toxicity, even going to the doctor's toxicity, I submit. Basically, less visits, certainly less cost for the society. Combinations, what to do with combinations. This is really the problem of the next 10 or 20 years. And as Jeff said, it's not only binary, but it's now ternary and even quaternary treatment combinations that we need to figure out how to test. I submit, and we have a big FDA meeting in October to debate this further, that we shouldn't be doing trials the way we have in the past, treat 1,500 people and wait for the stone to hit the pond and splash. We should be testing in adaptive fashions that assign people to the better treatment arms as we go. And with a very smart biostatistician, Don Berry, people at the FDA and an international working group, we're actually now developing an adaptive trial that we hope to launch where new agents after PD-1 failure will be available for patients worldwide in a more rational, more efficient fashion. So the next question then is, maybe these therapies which work in impressive new fashions, if they were given earlier at the stage that you just had the lymph node resected, you knew that you had a 40, 60, or 80% chance that cancer would come back, maybe it would work better. Before I go there, just to let you know, we don't even know whether it's better to give double molecular therapy blocking BRAF and MEK or double immunotherapy. And so what we call the Dream Doublet trial, I want you all to know about. Again, teaching you is more important than teaching my residents, fellows, etc., that there is this trial. If a patient is BRAF mutated melanoma metastatic, that randomly assigns one or the other, but nobody is assigned to one or the other forever, because there's crossover at progression. and we need to do this trial. We need you to understand this is the current state of the art. This is the way we should make progress, because if we answer this question, then in the way that Jeff suggested with the IPI following Nivo may be better, we'd understand whether double molecular therapy or double immunotherapy is the better way. One is your left jab, the other is your right roundhouse, and I think you need both, but we don't know yet, and we need to admit we don't know which to do. Are there ways to do ternary therapy that may be both better and less toxic? So we did a trial that I have to say I didn't expect was going to be positive. Steve Hodai was the lead on this. We called it ECOG 1608, and this gave IPI at high dose, the dose that wasn't approved to treat advanced melanoma, with a drug that we all wondered really would work at all, but had been tested and tested and tested again, called GM-CSF, a growth factor for your white cells. And this is not a small trial. This is 250 people, half on the IPI, half on the IPI with the GM, and this is the results. So again, as Jeff portrayed, you want to be on the yellow line, which was the treatment with GM plus IPI. The outcome for survival was better, and significantly so. The toxicity was less with the combination. And the funny thing is, on the right, there was no difference in the progression-free survival, which we really have to scratch our heads and say, how do we figure them apples? And basically, because we never believe one trial, and I don't want you to believe one trial, this is not to go home to do, we're testing this again. So the current trial for BRAF non-mutated patients, if you hear from somebody who needs to find a new trial, IPI-Nivo, the most active combination, as Jeff already showed you, the most active combination we've ever seen, plus or minus GM-CSF. Will it be better with IPI-Nivo GM than IPI-Nivo alone? Will it be less toxic? Both are important questions. And so this is the design of the study. EA, now it's called ECOG Akron because we got married to another cooperative group. Basically, this is the current intergroup trial for people who are not BRAF mutated. So a future option is to put together the molecular therapy and the immunotherapy. The paradigm for this is if this is immunotherapy, durable, flat curves, long after you treated the patient. This is the paradigm for molecular therapy, great bang up front, but 9 months later, it's back. If we do the two, maybe we get a bigger bang, and it's also durable. So bunches of trials. It turns out that if you give BRAF inhibitors with CTLA-4 blockers, you've got intolerable toxicity, liver toxicity in the main. BRAF and IL-2, BRAF and interferon, BRAF and pembrolizumab, all of these are ongoing. But where I really wanted to get to, and I guess, Shelby, you'll have to tell me, should I cut?
I don't actually have an agenda in front of me. You're fine.
Okay.
We'll cut you off.
I could stop. Go from this area, which is what we've been talking about, to this area, which is 3 times larger, and I submit 3 times more important to hit, because if we could stop the tumor from coming back in Bobby and Caden, we would be a country mile ahead, because nobody wants to see this tumor back. So you heard about stage 2A melanoma that invades moderately deeply into the skin. Stage 2B, it invades deeper, or it's ulcerated, making the stage go up. Stage 2C, even more locally advanced, but no lymph nodes in those patients. And then the tumor's traveled. And this tumor cooperates a little bit because it travels 2/3 of the time by the lymphatics, so we can map them. As Caden told you, you can map and take out the first train station on the tracks from the tumor into the body. If there ain't no bad guys in that train station, you can say to a 90, maybe 95% confidence, tumor did not go to the lymph nodes. Huge advance. What do we have? We have a drug, interferon, which people either hate to love or love to hate. That in metastatic disease, which we tested in 20 trials, doesn't work very well. 15, 16%, maybe a third of them complete, but the truth is it never even got approved in metastatic disease treatment. But when we give it as an adjuvant therapy, reduces relapses by a third. So that, to me, is a lesson that the drug, which is so-so in metastatic disease, can be much better if you treat microscopic earlier disease. IPI, you saw the data, Jeff showed you the plots. 10% is what it gives us in metastatic disease. But we already know, 2 years ago, they approved interferon, in fact, this past year, ipilimumab, this past year at high dose because it reduces relapses by 25%. 2 different drugs, 2 immunotherapies work better, I submit, in the adjuvant setting. So the approvals you know about, these are the data, and it's way too hard to see, but this was presented as a debate in our national meetings of the ASCO. Should people consider high-dose interferon the standard? And Mike Atkins, our colleague from George Washington, basically showed us data that both survival and progression-free interval are improved significantly in 2 US randomized trials. So this is the data that we have. The survival benefit, I submit, is the most important thing. And these are the plots, these curves. No question in anybody's mind, you want to be on the yellow one, not the observation blue one. And these are very mature data now with significant differences in those who are alive with the interferon as opposed to alive with the assignment to observation. So we wanted to beat interferon with a vaccine. So the largest mature trial we've ever done in the US was a vaccine called GMK. It was the favored vaccine out of Memorial at the time, and basically it was stopped, this trial. When you do as many trials as I've done, stopping can mean one of 2 things. Either you hit the home run, not very often, or your trial failed. And this trial was stopped because the vaccine, the GMK vaccine, failed and had a time and a half as many deaths as the interferon. Think it the other way around. Think it that the interferon had 1/3 less deaths, 1/3 less relapses. And that was the second trial to confirm the benefit of the interferon. So the toxicities, and everybody, as I said, either hates to love this or loves to hate this, but fatigue is the reason most people stop this treatment. Adolescents and younger kids basically don't get that fatigue. And so that's why, as Brenda mentioned, it's easier to treat kids. And we have 3 or 4 currently on adjuvant interferon in our clinic with these same spitzoid melanomas that you heard about so eloquently. Without the fatigue, this is a hell of a lot more tolerable a drug. The other toxicities are all non-fatal. It was 30 years ago, the last toxic deaths of liver side effects, and those happened only because people didn't monitor and stop treatment when they could have. And if you stop when the performance status, the function, the level that the patient can do their daily activities, I submit you can get, and we've proven that you can get more than 90% of people through a whole year of this therapy. Well, what if you grind up and homogenize all the 22 trials that have gone on for interferon and say, regardless of the dose, regardless of the duration, what is the benefit? That's what we call a meta-analysis. And the bottom line is there have been several of these, and they all show interferon benefits. It reduces, on average, 20% the relapses and about 10% the deaths. And I submit that this is still something that we need to offer to our patients because it's something which we know 22 times works. And it works in all groups, which is really what this plot shows. And I'm late, so I'm going to skip all these things. We've analyzed the differences. I'm going to skip this. And it's important to say 1 month does not do the job. We will publish, I hope, in the next few months, a trial that took us 15 years to finish, which was 1 month versus observation, hoping that 1 month would do the trick. Sadly, it didn't. That study was also closed early for failure. So, what predicts who benefits? Jeff showed you the half-white mouse. Helen Gogas, working in the Hellenic Oncology Group, showed that people who got autoimmunity, the top line, did a heck of a lot better than people who didn't get autoimmunity. Most of this was thyroid overactivity, thyroid underactivity. So I submit, when we see collateral damage, we know at least the missile has landed, and we know the potential for benefit is there. So this is the newest basis of data. We'll all hear this on the 7th of October in Denmark. Copenhagen is where the European Society of Medical Oncology will hear the survival outcome for this very important trial of IPI as an adjuvant. Nearly 500 people got assigned to induction and maintenance with IPI for 3 years, or placebo. So that's the right way to do this kind of a trial. Placebo protects us against ourselves, and this is the data. And Bobby mentioned it before, but I want to say that my interpretation of both the IPI and the interferon data is a little different. And I don't have time for stories, but Stephen Jay Gould has written an important little article that I'm sure many of you have read. It's called "The Message, the Median is Not the Message." What it means is that the median, which is here, the point at which the middle patient in 100 relapses, isn't really what you care about, is it? I submit every person in this room, both us medically and you all as patients and patient supporters, really care about this tail end of the curve. Are we curing people or are we not curing people? So the median prolongation of 9 months, I never mention to patients because I only really care, are they cured? Are they 2, 5, 10 years later likely to be free of disease? For IPI, we don't know that data yet. But when this was presented by my colleague Lex Egermont, the credit there, in 2014, I jumped up at ASCO. I said, this drug shouldn't have worked to prevent relapse, should it? It worked far better on survival in the data that Jeff presented. For the pivotal trial, it was marginal in terms of showing disease response, but it had its biggest impact on survival. And that's what we can hope for out of this in the future. But 1% of patients died of toxicity. This is a hurdle. In adjuvant treatment, if your patient wasn't going to relapse and they died of toxicity, it's even a bigger hurdle. So I think we need to figure out what's the right dose. The US trial that you'll see the results of probably a year from now is 1609. This is the trial. 500 patients got high-dose IPI, 500 patients got low-dose IPI, the bottom box, and the other 500 patients got our standard interferon. This trial is the trial you all, we all, and I'm sure BMS all want to see the results of, because if 3 is as good as 10, I submit we go forward and nobody asks any questions about this anymore. So how to develop better combinations? I think this is a little dense, but I think combining CTLA-4 and PD-1 with interferon, something we've done for now a few years. Interferon plus CTLA-4 is the first one because they work through different immune mechanisms. The benefits are additive. So the patients who develop major and even sometimes complete responses in their disease with the combination of CTLA-4 blockade and interferon was better than without. We now, as I said, we don't trust any data once, so we tested this again. The National Cooperative Group Trial testing is interferon plus IPI at 3 or interferon plus IPI at 10. Better. That trial was just closed, will be analyzed. We should have the data by the spring. So the data is coming shortly. And you all want us to find things out in months, not years. How can we find things out in months, not years? So the last little bit I wanted to share with you is neoadjuvant therapy. What this means is giving your adjuvant therapy before you do your surgery. Patient comes in with a lymph node, multiple nodes are seen on PET. You take a biopsy of one and you treat for 6 weeks. What do you find out? Well, you basically find out when you do this with interferon. The first trial we did, and this is published now 10 years ago, so started 15 years ago, before treatment, T cells, before treatment, the macrophages that Jeff told you about in the beginning. On the right, the red dots are more numerous. The T cells and the dendritic cells are clearly increased in the tumor, and a signaling molecule which inhibits the immune system, called STAT3, is washed out. So we think treating for just 4 weeks before you do your surgery may do a whole lot better. It certainly may accelerate progress, and we've done this with IPI, and since IPI is what you've heard about several times before, pretreatment, here, PET positive sugar burning tumor in the maxillary node, just 6 weeks later, nearly 95% gone. Pathology for that, almost no tumor cells living. How about combining interferon and IPI? So this year at ASCO, we presented this data. And again, it's the question of which dose, 3 or 10 of IPI is better. If they're the same, we want the less toxic 3 dose. And so I'm going to skip the details on this and just say that when you look at IPI at 3 milligrams or IPI at 10 milligrams, the benefits in terms of anti-tumor effects radiologically and pathologically are identical. So we don't have data that says the 10 is better than the 3 given before surgery in combination with interferon. And basically, these are the plots that support that. So neoadjuvant combinations tell us in weeks, at most a couple or 3 months, what takes us 10 years to find out when we do big clinical trials. So this is the current intergroup trial. Again, my job is to teach you, to teach others. When you come in with a lymph node that's involved with tumor, the option now is pembro anti-PD-1 for a year versus interferon. And as of last November, we added IPI to this. And the primary goal of this is survival. So I'm going to skip all these last things and say that interferon as an adjuvant therapy works. It works, I submit, not much differently than the ipilimumab that we have had approved just last November. Anti-PD-1 probably works, and we all, I think, believe it'll work many times better and potentially be less toxic. All of these are the outcome of clinical trials, and I thank you all and all of my colleagues for having allowed these trials to go forward. So, a little less over time, but thank you.
We'll do questions in just a few minutes. So thank you very much. I think you've gotten a picture of what I would call the art and the science of medicine. The science is the foundation. Knowing this data, I mean, I can't imagine keeping all this data in your brain. And you know, both of these physicians and even last night, Dr. Davila could give this stuff without the slides. They know this stuff. But then at some point you have to make judgment calls and you know, what does this mean that this tumor looks like it's getting bigger, but maybe it's not getting worse? So we've seen the art and the science. It's been fantastic.